What I want to try to convey to you is things that I've learned over the last 15 to 20 years about how medicine has changed and how I think we have to arrive at a new model for patient care because the patients are demanding it. And I know this is a fairly diverse audience. Obviously, we're mostly surgeons in the room and students and other stem cells of those kinds, but any program that you're associated with can, I think the lessons can be applied. So I want to start off with this picture, which is very familiar to all of you. How do you think this project started? Just think about how this got built. And I predict that a group of people got in a room and designed this and said, what do you want it to look like, and how tall does it need to be, and what's the order of events, and when do we pour the cement, and when do we put the steel, and architects and engineers, and all of these people got organized and then said, okay, what date are we starting? And that sounds extremely logical for this project, but I can tell you in medicine it's rarely done this way. In medicine, the colorectal surgeon may take care of a colorectal problem and not really worry about the fact that there's a bladder issue with that particular patient because they don't think about it. And then 6 months later, the urologist meets the patient and realizes they have to do some intervention, and now the patient's already had a laparotomy for their colon problem, and it's completely uncoordinated. And you all know exactly what I'm talking about. And it's not great care. So my focus has been this book. Has anyone read it? Anyone read it to your kids? I'm very passionate about the deeper meaning of this book because what you have to recognize is there's a sequel to this book, and that's this book. So my exposure, as James said, was actually from medical school when I met the icon in our particular field in pediatric colorectal surgery, and that has been my focus ever since. And Alberto Pena, who some of you in this room know well, was a consummate clinician who took care of all aspects of a patient's care. And he would joke that if the office line rang and they said, can I speak to the colorectal surgeon? He would say, that's me. All right, can you now connect me? I have, my daughter has a urology problem. And he would say, that's me, I'll take care of that as well. Oh, and I'm going to need to talk to a gynecologist, and he would say, I got you covered. How about social work, psychology, nutrition? I'll take care of all of that. And I watched that as a medical student, and he did a marvelous job at that time, but medicine got more and more complicated, and I felt progressively incompetent in taking care of the other subspecialty problems. And because the days were changing, and there's a ancient photograph of myself as a medical student. You know, you talk about serendipity, right? So medical students in the room might be deans in 10 years, but I can tell you as a medical student, I almost didn't meet Alberto Pena. I was assigned to a different elective as a fourth-year medical student, but that elective was blocked by another student. And that student was a friend of mine and said, go look in the book. I think there's another elective in pediatric surgery with some guy named Pena. Why don't you check it out? And I called their office and said, yeah, we can take a student, no problem. And that began the adventure. Take a look at this picture. So a kindergarten class was asked to draw a picture of what they thought their mother did for work. Take a look, see what you think. So there's some giggles in the room, and I suspect most of you see a woman who's probably not wearing much, standing next to a pole with men handing her $1 bills. And the purpose of this picture is to show you the importance of context, right? Because the true story was that she worked at a Home Depot, and it was a snowy day, and there was only one shovel left to sell. And everyone wanted the last shovel. You guys don't probably know what this is, but that's called snow on the right. But context. So I was at a unique vantage point. I was budding medical student, junior resident, watching complex care being done by a single individual, recognizing that medicine was getting more and more complicated, subspecialty care was becoming more important in pediatric surgery, and I thought I saw the future was to make care more comprehensive. And so I had a unique vantage point. Because in the care of children with colorectal problems, and this is a fetal MRI, so this is a 20-week fetus, and obviously I've drawn in the blue highlights, but those are the bladder, gynecologic system, and rectum, all in the pelvis. And traditionally, these three areas of physiology and anatomy were managed by three completely separate entities, so groups of doctors that didn't really talk to each other. And I think from a better planning point of view, to make the care of this child more similar to building of the Golden Gate Bridge, we all need to talk to each other and collaborate and coordinate our efforts in advance, because medicine is very complicated, and these children, in particular in colorectal, have problems in all of these areas, and all of them interact with each other. So we start to talk about the regionalization of care, of how to care for complex problems, and I think if we use our European colleagues, and particularly those in the UK, this in pediatric surgery, they have declared that biliary atresia and bladder exstrophy, two very complex diagnoses in the pediatric world, can only be cared for at certain medical centers in the UK, because they recognize that gaining experience was going to improve outcomes. And it's very difficult for us in the United States to do this by a different insurance model, but I think the patients are demanding it, and institutions that commit to center of excellence care, and that's sort of the purpose of what I'm trying to convey to you today, will get those patients and will show that they have better outcomes, and ultimately the insurance companies, I predict, will follow suit, as many of them have. I mean, for example, in I think it's Walmart, if you need coronary surgery, you go to Cleveland Clinic at the moment, anywhere you are in the United States, because they've decided that that is their go-to place for open heart surgery for their employees. So some examples in pediatric surgery of the center concept, and you've probably heard of these kind of programs, but I think the secret sauce is how to develop the concept of the center and how to integrate the people that need to be present. And it's not just based on the sweat and tears of the clinicians showing up at a collaborative clinic. It's the administration that needs to make it easy and to incentivize those participants to collaborate. And in pediatric surgery, the current situation in colorectal is quite daunting if you think about it. If there are about 600 newborns with an anorectal malformation born per year in the United States, a pediatric surgery fellow, like at a program like this, probably does about 14 cases in 2 years, and a graduate does about 1 case per year. How are these individuals supposed to keep good skills? And how are they supposed to get good outcomes? Because I think, frankly, for me, this has become a moral imperative, because the complications are really quite impressive, from fecal incontinence to urinary incontinence to renal dysfunction and the need for renal transplant, sexual dysfunction, and infertility. And I put this sand timer on the side there as a reminder that in colorectal surgery, if you do an operation as a 6-month-old, you might not do a great job, but you don't really know that you didn't do a great job. Because if you put the anus outside of the sphincters, the 6-month-old won't really know that until they are 4 years old and trying to successfully potty train. And how's the surgeon supposed to remember that 4 years ago they didn't do a great maneuver to put the anus in the right place? They will never figure that out, and they will keep doing the same mistake over and over again. So now, unfortunately, this video didn't play, but I found it here on the internet, and this is a very important video for surgeons to watch. So let's see if this works, and hopefully there's sound. Is there sound? No. No sound. Anyway, we can watch this play out. Oh. Anyway. anyway, just watch. So these are two wildebeests checking out this thing that they're talking about. Okay, so it's clear to everyone in the room that those were surgeons, right? Did you notice how long it took surgeon 2 to admit that he was wrong? Did you see that? Like, no, it couldn't possibly be the case. So the reason why I like that video so much is that we, as surgeons, never really admit that we could possibly have that complication until it happens to us personally. So in colorectal surgery, the lesson, I think, is that there are a lot of complications out there, and if you learn certain pitfalls and techniques of getting it right, you don't have to personally be eaten by the crocodile. And unfortunately, right now, my practice is about 60% reoperative surgery. And that's not right. We obviously shouldn't be doing reoperative surgery. We should be doing better primary surgery, which gave me this idea, and that is to launch this collaborative concept of putting together colorectal surgery, gynecologic surgery, urologic surgery, and then the medical part, the GI motility part, with the attempt that then 1 + 1 could actually equal 3 if that unit of surgeons and medical people worked well together. This is not a crazy concept. This is well done in many industries, like I described, the bridge builders, marketing teams, et cetera, routinely bring all the skills together, sit at a table, and make a plan. And in medicine, we just don't do it well. So how do you develop a center? I'm going to try to go through the recipe here, and that is, first of all, you need a clinician with unique skills. You have to define the impact that it will have on the hospital. This is really an important concept, particularly for administrators to understand, because the impact is quite dramatic. You have to gather the appropriate personnel, identify the needed support, figure out how you can share resources amongst the different collaborators, market the idea, and then have an academic plan. So the unique skill concept, I think, can't be underestimated. You need actually a clinician, in this case a surgeon, who can actually do the complex cases and has the capacity to develop a reputation that the patients seek and the fellow clinicians seek that individual out. And you have many examples of that in your department. You have to define the problem and what is its scope. And in pediatric colorectal surgery, it's quite diverse as far as the number of specialties that need to be involved. And then you have to define the hospital impact. And I think this is probably the most important concept. So if a patient is referred to me with an anorectal malformation, and I repair that, but the patient has an associated spinal problem, and they meet the neurosurgeon with their spinal problem, and that spinal problem needs surgery, one can make the argument that because of the creation of the program and the collaborative model, the spinal surgery was facilitated by the fact that a program existed. In most administrations, that doesn't make any sense. The neurosurgeons get the credit for the tethered cord release, and the pediatric surgeon gets the credit for the colorectal repair, and neither the two shall ever meet. But if you talk about it from a programmatic point of view, then you can conclude that, in fact, drawing in of the complex patient facilitated a lot of care. And I think from an administrative point of view, we're able to track that data. It's very powerful. So these are all the specialties that I need to interact with on a fairly regular basis, and whatever program you are connected to, you can make your own list. And the challenge is actually to take care of patients from that 20-week fetus that I showed you all the way through until she can have a baby of her own and then is an adult because maybe she has a pelvic floor problem that Brooke Gerlin needs to solve at age 70. So if we take the patient from fetus to age 70 or 80, that's a pretty comprehensive amount of care that these patients will require. And not to bore you with this slide, but In our field, and everyone can make their own list, what is the hospital impact? Surgical cases, how many collaborative cases were done, how many non-surgical cases, the other consultations that you use, PICC lines, et cetera. All of these things are instigated by the patient who had the colorectal problem and then comes into the hospital and then starts utilizing services. So how do we track our success? I think if you're going to commit to a program, you need to commit to tracking of your success and commit to certain outcomes. So I think this is a vital slide, and that is we track things like collaborative RVUs. So for example, if I have the capacity to do a cystoscopy, but if I invite a urologist to do that cystoscopy, that should be good for the program. I should be encouraged to have the urologist present for that cystoscopy while I'm examining the rectum at the same time, because the patient gets comprehensive care. In the traditional model, that would be a bad thing for me because I do less surgery, because I could have done the cystoscopy, but I give the RVUs to someone else. You need an administrative model that says, no, that's a good thing because you get credit for the collaborative approach. Total clinic visits, downstream revenue. The hospitals know this data. You just have to ask them for it. How many patients are coming outside of your catchment area for the program? And then you need to commit to certain deliverables like publishing of your outcomes. You can't just claim that you're a center of excellence and unless you actually do center of excellence level care. A very good example in the adult world is rectal cancer. And some of you may know that rectal cancer requires center of excellence care as designated by the American College of Surgeons. You can't just do rectal cancer surgery wherever you want, because the colorectal surgeons made the argument that you need radiation therapy and oncology. You need a whole list of things in order to provide best outcomes. And this is an example of that in pediatric colorectal surgery. Quality improvement projects, patient satisfaction, and staff satisfaction. Are you able to retain staff, and are they happy? So this graph shows, without the numbers, but basically the progression of the program that I've been connected to for the last 5 years of hospital impact. And it's tracking the medical record numbers of the patients that came specifically for the program. And it demonstrates pretty significant growth in a number of areas of the hospital that you wouldn't necessarily think would be affected by a patient with a colorectal problem. So you got to gather the appropriate personnel, and I can tell you in this particular case, the infrastructure, the institutional commitment to infrastructure is vital, and the devil is in the details. And it reminded me of this poster that I saw at my daughter's high school. Now they're all graduated, but it said, "Let's eat, Grandpa. Let's eat, comma, Grandpa. Punctuation saves lives." So where those commas and where those T's get crossed and how those I's get dotted is really the secret sauce here. And in our world, we needed GI and gynecology and urology and a colorectal surgeon to work well together. And this is the personnel that is relevant on our particular team: surgical faculty, medical faculty, coordinators, et cetera, OR schedulers, social workers. All of this comprehensive care is what it took to get the job done. And to illustrate that in a very sort of divisional way, remember that most institutions are set up in a very siloed approach. Well, in our world, this silo doesn't work because it doesn't allow for integrated care. So for example, if I do a 10-hour operation that requires urology and gynecologic collaboration, who gets credit for the 10 hours of work? Do I get all the RVUs? Do they get some RVUs? What if gynecology is only needed for 2 hours? Do they look like a slacker that they only work 2 hours that day? Because it's not like they can do a lot of other things. They need to basically wait around until their part of this 10-hour operation comes together. Well, the only way to solve that is to make everyone connected to that centralized pot of whatever you're tracking, RVU, OR minutes, billings, et cetera, and everyone is part of it. Because I can't do the operation by myself. Why should I get the credit? Urology and gynecology are vital to the care of that child. Marketing is key. So how do you let everybody know? I think this is an important challenge as this institution embarks on a marketing program for pediatric colorectal care, which I'm very enthusiastic about helping with. You have to make sure that you understand how to market. So this is a good example of that. This was a New York Times ad from Michigan. I know there's some Michigan fans in the room, including myself, although I have one child that graduated from Michigan and one is now currently at Ohio State. So we have a bit of a house divided. But it's very easy to advertise for a pediatric heart program, as this kid is demonstrating his scar. I don't think we can put similar ads in the New York Times magazine, but we need sophisticated marketing that tells the world that we take care of children that have fecal incontinence. Not so easy to do. So I want to go through a couple of examples of what we've been able to achieve by the collaborative model. And I like this picture of what most people think it takes to do complex colorectal care is illustrated by the picture on the left. But the picture on the right is the truth of what it really takes, and it's a heavy lift. So, for example, we've done a lot better with prenatal diagnosis now that we have a collaborative model because prenatal diagnosers, obstetricians, high-risk OB kind of people, they don't necessarily know what a cloaca looks like when the baby's ultimately born, so collaborating with them and recognizing various anomalies that are recognizable in a 20-week fetus has really made for an improved prenatal diagnosis and a better planning for when the baby's born, where the baby is going to be born. Management of the newborn. This is a baby with a cloaca, with a mass in the abdomen filled with, this is a vagina filled with urine, and how to manage that patient. That baby can't just be born anywhere. That baby needs to be born somewhere that has really solid radiology and has pediatric surgeons and urologists and gynecologists that can intervene right away. And recognizing the importance of the urologic anomalies. You don't want to have a pediatric surgeon managing a child with a colorectal problem and then 5 years later discovering that the patient has a urologic problem that no one ever knew about, because at that point they may have renal damage. So collaborating up front. These patients are by design collaborative patients. And that's a challenge for a surgeon to sort of give up some ownership. We have to share the credit. That's not easy for surgeons, but it's obviously much better for the patient's care. Our collaboration with gynecology has been vitally important. These patients many times have Mullerian anomalies. They have hemisystems. These are not things you want to discover when they have pelvic pain at the age of 13 because their Mullerian structure is not draining menstrual blood. This is something you want to know about when they're 6 months old, when you're in their abdomen doing their cloacal reconstruction. And if you don't collaborate at that point or think about gynecology at that point, you're setting yourself up for a very difficult problem 13 years down the road. Knowing the associated sacral and spinal problems has been vital and in fact has allowed us to better predict continence. So we can actually now have a conversation with a family in the neonatal unit about their baby born with a colorectal problem and tell them everything's going to be okay. Your child very likely will be continent with the proper management laid out over the next several years. Or there's not really a lot of chance for continence because of the associated spinal problem, but don't worry, we have a bowel management program and your child will be clean and in normal underwear. Imagine the conversation that you're having with a 1 week old, the parents of a 1 week old baby. We couldn't do that before. It was sort of like roll the dice, see you in a few years. We don't have to do that anymore because of the collaborative model. And then defining of the anatomy, I think, was a big advance. When I was at Musée d'Orsay in Paris, some of you look around and at the art, I was on a mission to find the ideal elbow because what I saw was that, right? That's what I saw because what surgeons were not doing is properly defining the rectourethral anatomy of children born with congenital colorectal problems. So if the fistula from the colon to the urinary system is at the deltoid, we call that a bladder neck fistula. If it was at the tricep, we call that a prostatic fistula. It was at the elbow, we call that a bulbar fistula. So now surgeons all over the world are writing in their operative notes one of these three categories, and we are properly tracking data instead of saying rectourethral fistula with no defined anatomy. That was very important because each of these diagnoses have a different surgical approach, and a different potential outcome. And the redo, I mentioned the redo situation, so here's some data. Some of it positive because we are helping children by reoperating on them, but you got to think about the inherent problem is that we shouldn't be really doing redos at all. And it's quite remarkable how many times I meet a patient in whom the surgeon put the anus in the wrong place. And this is an anoplasty that is, to your own eye, you may be able to see, is too, and maybe this works, we'll see. No, it doesn't work. But that anus is too far posterior. The center of the sphincter is right there. Patient needs a reoperation. And there's a stricture, and there is a remnant of the original fistula. The surgeon didn't properly remove the very end of the rectum. They left it behind, causing a whole host of problems, and then rectal prolapse. These are technical problems that are solvable with better technique. Now, the good news is that redoing these patients, and again, I never wanted to become a redoer of surgery, but we can actually dramatically improve their functional outcome and quality of life. And this slide shows that we were able to convert a good number of these patients to continence by making them have better anatomy. So as the surgeon, your responsibility is to get good anatomy. That's what we're all about. But then we have to recognize that after you've achieved that goal, there's a functional outcome that's relevant. We were talking about this a little bit yesterday. You can do a perfectly good Nissen, but it requires some tinkering over time to try to get the best possible result for that patient. Here's a nice example of a collaborative model. So we tracked our colostomy and ileostomy closure surgical site infections. And I don't know if you know what your current rate of infection is, but if you're not tracking it, you probably think it's pretty low and everything's great. But if you are tracking it, you'll recognize that it's not an insignificant number. So ours was 22.4% wound infection rate. It's pretty standard in the literature. So we implemented a GI bundle, which I think probably the most important component of which was before closing the fascia, we changed instruments and gloves. And by simply doing that, we got our rate down to 7.9%. And then we said we could do better than that, and we changed one item, and that was the preoperative antibiotic, because what we did was we took the organism that was growing in the wounds and compared it to the preoperative antibiotics that was given, and in every circumstance, the organism that ultimately grew was resistant to the dose that was given within an hour of incision. So with ID, we picked a different drug, so we went from cefoxitin to Unison, and now our rate is 2.2%, which is really, really good. So the lesson of this study is that, first of all, you have to track your data. You have to have outcomes. You have to say, what are the outcomes we want to follow, what's important? And the amount of morbidity that's involved with wound infection is quite significant. And then you have to say, well, how do we fix that? How do we improve that? And you have a group get together and say, well, let's wash the skin preoperatively, or let's change our instruments, or let's change our gloves, or what if the antibiotic is a problem? And then you continue to track your data. I think the best example I ever saw of this was an ICU that tracked their line infection rate, and they knew what it was every single month, and it, something like 2%. And 1 month it was 4.5%. And they knew within a month that something dramatically had changed. And they convened a meeting and said, what has happened here? And it turns out that the little cap that goes on the central lines was from a new company. And someone suggested maybe that was the problem. And they changed the cap back to the old cap, and the rate went down to 2%. Had they not had that data, had they not had that knowledge, they would have been sitting there at 4.5%, with the amount of morbidity that was causing without even knowing about it. Another example is defining the cloacal anatomy and figuring out that, in fact, and I suspect this won't work either. Yeah, none of the videos are working, unfortunately. This is a very cool 3D reconstruction of a cloacal malformation. But surgery was being done without knowing the anatomy well, and the wrong operations were chosen, and we decided that you have to measure both the common channel length and the urethral length and make a plan accordingly. And if the urethra was going to ultimately be shorter than 1.5 centimeters, Denny is well aware of this anatomy. We've been talking about this kind of stuff for 20 years. You would then bring the bladder neck down to the perineum and make a wet patient. They couldn't control their urine. So we learned that if you leave enough of a urethra behind at the end of the reconstruction, you could have a dry patient 4 years hence. You need to know what's going to happen in 4 years. You need to plan your surgery accordingly. If you're not tracking your data, you have no idea that you've caused any sort of morbidity. Now I can skip that. And here's basically 3 examples of 3 different lengths of urethra, nice and long, about medium size, and no urethra at all. Different operative approaches based on what your urethra is going to be. So urinary reconstruction, I think that has probably been the most dramatic. I don't know how many of you work with your urologists, but there's a lot of work that colorectal surgeons and urologists do, at least in pediatrics, that ought to be done in a coordinated way. This was a gift that I gave to our graduating fellow. It's an inside joke, cloaca, single perineal orifice. I don't know if everyone sort of gets that joke, but I can tell you, you can get a custom-made bowling ball quite easily. Just order it from the internet. The challenge is then you need the holes drilled. So I just want you to think about me at a bowling alley having a conversation with the guy who drills the holes and asking them if they would be so kind as to only drill 1 hole, because it was a gift for someone who knew about cloacas. This whole conversation about cloacas, and it was really quite funny, and the really nice thing is he only charged me 1/3 of the normal price. So we collaborate very well with our urologist, and he gave us this gift. He has one that says liquid waste management, and we are the managers of the solid waste. So, but for example, in this example, a 6-year-old with myelomeningocele who has urinary and fecal continence. In the before version, the urologist may have done a bladder augmentation, Mitrofanoff, and all of that work to get them dry for urine, and not worried about the colon at all. If the colorectal surgeon got their hands on this patient, they may have done some colonic surgery, a antegrade enema option, etc. If that gets collaborated, if that gets coordinated, then you could do something crazy like take out the sigmoid to improve the bowel care, but don't throw it out, keep it on its mesentery, and roll it over and use it for the augmentation of the bladder. The only way to do that is to plan that operation in advance in collaboration with urology and colorectal surgery. And then you could even take the appendix and share the appendix between Malone and Mitrofanoff. The only way to do that is with coordinated care. So we have this sort of joke that I don't use the appendix for a Malone antegrade enema option unless I know that the urologist doesn't need it for their Mitrofanoff. So you may recognize this reference of receiving the golden ticket, and there I am receiving my golden ticket from urology. I now have permission to use the appendix for my purposes because they don't need it. The ultimate in collaborative care. This is not easy because obviously the surgeon is there, the clinic patient is there, and you want to just book the case. No, now you got to wait, you got to call urology, you got to get them to do their workup, you got to make sure that they're okay with you doing the operation. And just from a surgical technique point of view, it's very cool. You keep the appendiceal mesentery. I know many of you in the room enjoy taking out appendixes. We try to save them, and this is the proximal appendix becomes the antegrade access for enemas. These are patients that are fecally incontinent but can be made clean by a flush every single day, and therefore they're clean in normal underwear in somewhat of a mechanical way. And then this distal piece stays on its blood supply and can be implanted into the bladder for intermittent catheterization for urine, and they can be rendered dry, clean and dry for urine and stool in single operation. And we've learned a lot about fecal continence, about the sphincters, the anal canal sensation, and the impact of motility. And these are the children that we deal with that have these continence issues, anorectal malformations, Hirschsprung's, spinal problems, and those with severe functional constipation. And we've learned a lot from our GI motility colleagues, and there are certain patients that need surgical solutions to their constipation. In the adult world, that's a subtotal colectomy iliorectal. in our world, before the entire colon has dilated up, we may be able to get away with just a segmental resection of just the sigmoid, for example. So that collaboration with the GI medical people has been very, very valuable. I'll sort of skip some of these things. So then the question is, can we go regional? And these are some of the things you can think about as far as your own development of your own programs. Can we go global? And I think the way to do that is to write in the literature, because your fellow clinicians around the country and around the world read your articles and say, wow, they must really know what they're talking about at Stanford because they just wrote this beautiful article. The parents actually do their own Medline searches, and they know, and I'm sure you guys know that. They come into the office with stacks of articles and say, tell me more about this. You need to help the patients find you, so you need a committed marketing team that gives you a web presence. You need to be able to welcome those patients that are from afar. Where are they going to stay? What are they going to do with their with the other siblings in the pediatric model? And you need to travel. You need to go around and talk about what you're doing so that word gets out that you have a center of excellence. And I think it's important also to partner with other institutions. And this has been a very important mission of mine, is to develop this consortium. So we have the Pediatric Colorectal and Pelvic Learning Consortium, which is growing, and we're hoping that Stanford gets added to this list. And we are collecting data in a similar manner. We're at 2,200 patients now. It started 3 years ago. And we can at any moment say, what's the incidence of enterocolitis and Hirschsprung's disease across 15 centers? And I was talking about this with Dr. Crummell yesterday. This is the Sir Dennis Brown Medal, which is the BAPS, the British Associated Pediatric Surgery greatest honor. And on the back of that medal, it says that the aim of pediatric surgery is to set a standard, not to seek a monopoly. And I think that's really the lesson here, and that's really what has been my mission, is there's so many patients that need help, we just have to develop partner centers of excellence. And then we also need to recognize that there are a lot of patients that have no idea where Ohio is or where California is, and we have to go to them. So I think having a group of surgeons that are committed to going forth into the developing world and helping children there is pretty important. And then I think it's important, of course, to develop an academic plan, which I think starts with the educational mission. This is our course where people have come from all over to learn, and I think if you're viewed as an educator, then people generally think of you as probably a good clinician. And then we need to learn from our patients, and as we've mentioned on a number of examples, and therefore provide better care and follow longitudinal outcomes. And the only way to do that is to organize a database where you're collecting data every single day and then look back on how to track your result, because we would like to know if our bladder management in the 3-year-old is actually affecting whether or not they need a kidney transplant 20 years hence. What if we could reduce the incidence of kidney transplants by doing better bladder management at the age of 3? Pretty powerful. And this is another video that won't work, but basically this is an interactive database that we've developed, and that is prospectively collecting the data within the EMR and then measuring outcomes and getting real-time feedback. And this is something that's definitely doable, particularly with this consortium, but depending on what field you represent, you can do this as well. And I can tell you, and I'm about to get on a United Airlines flight in a number of hours, if there are delays out of SFO today, then tomorrow someone knows how many flights were over the 15-minute mark. Tomorrow, someone knows that fact. In most departments of surgery, you have no clue about that. Wound infection, death, line infection, all of those things, you don't know. You think you're doing well. Unless you're tracking it, you don't know. But I can tell you in industry, someone is going to be on the phone tomorrow and they'll explain, well, the runways are under construction as SFO and they'll be better in a few months. But there is an explanation. We don't have those kind of explanations as standard. We don't have typical audits of how patients are doing in surgery, and I think it's really, really important in order to improve our result. And then some interaction, of course, with basic scientists. Tissue engineering, I think, will revolutionize our field. This is a mouse with an ear growing on his back. Imagine if we could tissue engineer a piece of vagina. It will revolutionize the care of cloacal reconstruction. We won't need to use bowel anymore, and there's been a lot of work done with genetics. So I'm just going to leave you with this story, which is what gets me up in the morning. And so this 6-year-old girl had daily soiling, wearing a diaper, was teased at school, comes for our bowel management program, and I, somewhat off the cuff, tell her, in a week you'll be clean and in normal underwear. And she looked at me like, you're an adult and you have no clue. And I suspect some of you have seen that face on children. But a week later she came in and said, Dr. Levitt, you make good promises. And it really hit me, right? Because what are we after? We're after the changing of the quality of life. We're actually after the delivering of what the patient actually has asked for. A lot of complex medicine all comes down to the moment of truth when you're in the room, in that clinic room. There's no insurers in the room. There's no administrators in the room. It's just you and the patient, and they're asking for help, and you have to deliver that help. And then the question is, did you deliver what they asked for? And that's what all of this has been about. So to summarize, we talked about unique skills that need to be developed in order to create a program, understanding what the impact is on the hospital, and integrating the impact with developing resources for that program, gathering the needed personnel, understanding the support and the resources that were required, market the idea, and having an academic plan. And I thank you very much for your attention.